Good evening, all. I'm Dr. Chaitra, consultant pathologist at SigTuple. On behalf of SigTuple, I welcome you all to the third episode of SigTuple webinar in the series of digital pathology. So the topic for today's webinar is myeloid neoplasms. And today we have our guest speaker, Dr. Prerna Chowdhury, who is the lab head and consultant pathologist at HCG Cancer Hospital, Ranchi. She has done her MD pathology from Kasturba Medical College, Manipal. Her areas of interest is hemato-oncopathology. So she's been using our SigTuple AI 100 in her day-to-day practice to report oncology cases. So today she'll be sharing her experiences of using AI 100 in the oncology setup, and she will discuss a few interesting cases which was reported on AI 100. So today's agenda, we have 3 talks. We have a brief introduction to SigTuple AI 100 by myself, followed by WHO 2022 update on acute myeloid leukemias by Dr. Prerna. After which we have a talk by Dr. Pavitra, which is the update on other myeloid neoplasms. So let's start with the introduction, that is to introduction to SigTuple AI 100. So SigTuple is a medtech company which is based out in Bangalore. It's a pioneer in the field of digital pathology. So they have developed this AI 100, which is a fully automated digital cell morphology analyzer. So with the combined power of robotics, artificial intelligence, and medical data, so they have created a smart diagnostic solution. So with this, we are democratizing microscopy by enabling an AI-assisted remote review, which is unhindered by geographical boundaries. So how does this AI 100 work? So we prepare a peripheral smear, stain the smears, and load it into AI 100. So AI 100 works with both manual as well as the automated smears. And it is stain agnostic. So we can use Leishman stain, MGG, and bright stain. So once you load the slide into the AI 100, which is a smart robotic microscope, the optical system inside will scan the smear, and the camera inside it captures the images, and these images are transferred into the cloud, where the artificial intelligence enabled algorithm analyzes the data, computes it, and provides a report with a visual evidence. And this report can be viewed by the pathologist by any internet-enabled devices. So AI 100 is a one device with a multiple tests. So right now we have shown it for peripheral blood smears and Shrava for urine microscopy. So in the future, we will have the universal scanner for body fluids, bone marrows, histopathology, and cytology. So AI 100 has 3 key features. That is, first thing is it's accurate. So it has a high sensitivity and specificity, and it's affordable. And with a cloud-based remote review, it is more accessible. So we have our own software system called Mandara. So this is how it looks. So this is how the report looks with the visual evidence. And we also have a reference images of this. So in the WBC, it gives us a 7-part differential count, including the IGs and the blasts and the nucleated RBCs with the visual evidence. And it's very user-friendly. And it's with a single scroll, you can see all the images. So next, coming to the RBC. So RBCs are classified based on their size and shape, and it is graded as well according to the ICSH guidelines. So in the platelet category, it gives us the platelet count, just like our manual microscopy. So it gives us an average count of the 10 oil immersion fields, and it highlights the giant platelets and the platelet clumps. So we have an additional feature which is very special about AI 100 is microscopic view. So this simulates the manual microscopy. So with the visual evidence and this microscopic view, so AI 100 helps in transition from the manual microscopy to the world of digital microscopy. So this is our team. So with this brief introduction, I would like to end my talk. And I would like to welcome Dr. Prerna Chaudhary, the lab head and consultant pathologist at HCG Cancer Hospital, Ranchi, to enlighten us about the WHO 2022 update on acute myeloid leukemias. Over to you, Dr. Prerna.
Thank you for your kind words, Dr. Chatra. So, good evening, everyone. I'm Dr. Prerna Chaudhary. So, I will be taking a small talk on WHO 2022 update on acute myeloid leukemia. So, there are some major changes in this new WHO. First is there is enhanced grouping framework permitting scalable genetic classification, separation of AML with defining genetic abnormalities from AML defined by differentiation. So basically what they have done, they have put the two separate classification, one with genetic abnormalities and one by differentiation. Second is de-emphasizing blast enumeration. Earlier there was 20% blast requirement, but now it is only for BCR-ABL and AML with SEPA mutation. Third is introduction of AML with other defined genetic alterations. So they have put a new heading which, in which if there is some new mutations found, new and uncommon mutations can further be added in this AML with other defined genetic alterations. So, as you can see, this is 2019 WHO classification, and the next to it is 2022 WHO classification. So the provisional entity, which was AML with BCR-ABL1, has been given a proper space in the new WHO classification. Then this AML with myelodysplasia related, just a minute. Yeah, so AML with myelodysplasia related changes has been put into the heading of AML with defining genetic alterations. And as mentioned, with other defining genetic alteration has been put into 2022 classification. Then this AML with KMT2A mutation, which had a huge name with their mentioned allele and mentioned the ARMS mutation, has just now given a simple name, which is KMT2A rearrangement, because there is more than 80 mutations which was found in it. And as I already mentioned that BCR-ABL and SEPA mutation, you need 20% blast for its diagnosis. Others, you don't need 20% blast. So coming to KMT2A mutations, there are a few new additions in it. So AML with KMT2A rearrangement is the new term which has replaced AML with T911. As I told, more than 80 mutations fusion partners has been described, which is MLLT3, AFDN, ELL, and MLT10, which is the most common ones. In KMT2A mutation, adults have high blast count, usually with monocytic differentiation, and in children, KMT2A, MLLT3, and KMT2A, MLT10 show megakaryocytic differentiation and an or low blast count in bone marrow aspirate smears. Coming to NPM1 mutation. So AML with NPM1 mutation can be diagnosed irrespective of the blast count. There is more emphasis which is given on clinico-pathological correlation, because the previous data shows that if any case which was classified as MDS or MDS bar MPN with NP1 mutation has been progressing into AML in short period of time. So if there is NP1M mutation, it should be taken as AML and treatment should be given as such, because in future, it may progress into AML. So AML with SEPA mutation has changed to include biallelic and as well as single mutations. So three AML types with characteristic rearrangement involving KMT2A, MICOM, and NUP98 are recognized. A blast count under 20% is acceptable based on studies demonstrating that patients with less than 20% blast or any other of these mutations have clinical features of higher blast counts. So again, if there is these mutations, even if the blast count is less, we need to treat it as AML, and their clinical features will be like a high blast count, even though you are seeing less blast in the peripheral smear. The RUNX1 mutation in AML overlap with broad range of defining molecular features. So that is determined to lack enough of space to define a standalone AML type. So this has been removed. Coming to AML with myelodysplasia related changes is now called AML myelodysplasia related, which is AML-MR. Key changes which was introduced in new WHO was removal of morphology alone as a diagnostic premise to make a diagnosis of AML-MR. As mentioned before, now genetic, everything has become genetic now. Morphology is not the only thing which we can be dependent on, and we can start the treatment. So update on defining cytogenetic criteria is also included. Introduction of a mutation-based definition based on a set of 8 genes, which are SRSF2, SF3B1, U2AF1, and others. As you can see, these mutations, they comprise more than 90%, 95%, which are present specifically in AML arising post-MDS or MDS-MPN. So I put one table here. You can see 2016 cytogenetic abnormalities with AML in myelodysplasia related changes, and 2022. So what they have done is complex karyotype more than equal to 3 abnormalities they have included in defining cytogenetic abnormalities itself. Others unbalanced abnormalities are same, and they have introduced the new defining somatic mutation, which I had mentioned before. Coming to AML defined by differentiation, we all are very much aware of all this classification. The new thing introduced in this is, firstly, AML NOS has been removed from the classification. Second is AML acute erythroid leukemia is renamed. Earlier it was pure erythroid leukemia, now it's AEL, and it has a distinct AML type characterized by neoplastic proliferation of erythroid cells with features of maturation arrest and high prevalence of biallelic TP53 alteration. Diagnostic criteria which include is erythroid predominance more than equal to 80% of bone marrow elements, of which more than equal to 30% are pro-erythroblast or pro-normoblast. AMKL, acute megakaryoblastic leukemia, is associated with newly described RAM immunophenotype, which correlates with CBFA2T3, GLI-S2. Coming to myeloid sarcoma. Myeloid sarcoma represents a unique tissue-based manifestation of AML or transformed MDS, MDS-MPN, or MPN. So cases of de novo myeloid sarcoma should be investigated comprehensively, including cytogenetic and molecular studies for appropriate classification and planning therapy. So summarizing the entire tables, so there are many minor changes, there are many major changes. So summarizing everything, AML is arranged into 2 families, which is AML with defining genetic abnormalities, AML defined by differentiation. NOS is no longer applicable. Then AML with defining genetic abnormalities may be diagnosed with less than 20% blast, except SEBBA and RUNX. BCR-ABL. Then AML-MR replaces the former term AML with myelodysplasia related changes, and its diagnostic criteria are updated. AML transformation of MDS and MDS-MPN continues to be defined under AML-MR in view of the broader and defining biologic features. AML with rare fusions are incorporated as subtypes under AML with other defined genetic alterations, and AML with somatic RNX are RUNX1 mutation is not recognized as a distinct disease type due to lack of sufficient unifying characteristics. So I have few cases which was scanned in our center using AI100. So this is first case. It is a 54-year-old female. She was known case of AML, and the patient clinically was showing relapse. So we have scanned the slide for the same, and this view beautifully shows so many blasts in the peripheral sphere, and even the machine counts the blast to 29%. So we can see all these cells with high NC ratio, then immature looking chromatin, prominent nucleoli as well. So it was quite concordant with what we saw in the peripheral smear. The blast was 59%. We tend to count blasts more in the peripheral smear. This machine actually counts, like the field of view is 1,000 to 100. The field of view is too much. So they count all the field of view and then they give the percentage. So this was quite concordant and it was really helpful in diagnosing this case. Another case, which is of 72-year-old female with fatigue for 2 months and intermittent fever for 15 days. We had the slide of this patient and the machine showed atypical cells bar blast to 79.89, 80%. And we can see the images as well. There is these blasts, these are cup-shaped blasts, and very immature chromatin, very less cytoplasm. We can see the prominent nucleoli as well. So this was again quite concordant. This is the field of view. This is what we call is a microscopic view. It's just like you are seeing in the microscope, but it's in your screen. So you can show it to others as well. Sometimes the oncologists will also are very keen on seeing, okay, show me the blast, so we can show this to them. So this is the field of view, and we can see blasts. We have selected the blast here, and the machine has highlighted all the blasts. In same wise, if we select the lymphocyte, so the machine will show the lymphocyte as well. So again, on the peripheral smear, the blast was 92%. It was quite concordant. Then we even have a flow cytometry report of the same. It was HLA, DR, and CD34 negative. So coming to the next case, it is of 16-year-old female with fever and splenomegaly. So again, we have this slide of a 16-year-old girl. Blast came up to 77% in this case. It has, again, in the field of view, we can see blast cells, which are highlighted. We can click on this and we can see the enlarged version of it as well. The peripheral smear showed 65% of blast, very quite near the both of the results. Case 4, it is a 7-year-old female with hepatosplenomegaly and intermittent fever. This is the case in which the blasts are seen, again, very beautiful blasts. Field of view. We can see these beautiful blasts all highlighted. And we can change our view also in this. If you click this, some other view will come. If you click this, some other view will come. And the peripheral smear showed 70% blast. It was exactly the same. So it was really helpful in my cases. So what I felt advantage of using this device was remote reporting. In a few cases when there is pancytopenia, there is very less MDS cases, very less blasts are there. So and you really want someone else to also see. So in cases of dilemma, you can always take second opinion. That is reduced. It has increased the pathologist efficiency. There is less dependency on microscope. It provides crisp images, provide good microscopic images, and easy transition from your microscope to this device. There is a good database maintenance. And it's, of course, good for teaching and learning as we are doing in this. So what future it holds? Remote areas where there is no availability of any pathologist, it can give a pathologist point of view in certain smears. In urban cities also, when we go in some conference, we are out of office, and if there is sudden emergency and the doctor need the reporting of that smear, so you can log in and just see whatever the slide is and you can give the report. And it's an upcoming technology, then I think everyone should use it and everyone should be familiar with it. Thank you so much.
Thank you, Dr. Prerna. That was a very informative and a comprehensive talk. So any queries or questions, please post it on the chat box. We'll take it up in the end. So now I welcome Dr. Pavitra, consultant pathologist at SigTuple, to talk about 2022 WHO updates of other myeloid neoplasms. Over to you, Dr. Pavitra.
Thank you, Dr. Chaitra. A very good evening to all. So after hearing to the WHO 2022 updates on AML, let's move on to the other myeloid neoplasms. So I want to start off my talk with this beautiful slide of an AML case, which was reported at one of our client locations. And you can see there are multiple myeloblasts with beautiful aurochs. So coming to WHO 2022 update, what was the necessity for this 5th edition? The main aim being to incorporate all the newer genetic abnormalities which have been discovered in the recent past, and also to permit future scalability for newer and novel discoveries which keep happening. As you all know, with the new generation sequencing tests coming in, we are able to diagnose more and newer genetic abnormalities that also can be incorporated into the present WHO classification. And because in all the groups, you might see that there is an entity called with other defining genetic abnormalities. And also from now on, we have to designate the gene fusions with a double colon. Previously, BCR-ABL used to be represented by this, and now we represented it as a double colon between the implicated genes. Few newer terminologies have been introduced in the WHO this time. The main ones being clonal hematopoiesis. What is clonal hematopoiesis? This is a precursor myeloid disease state before a myeloid disease becomes overt. So this CH is a population of cells derived from a mutated multipotent progenitor cell harboring a selective growth pattern over the other cells. So selective growth advantage actually, and it should be seen in the absence of any unexplained cytopenias or any prior diagnosed hematological cancers or any clonal disorders. Under clonal hematopoiesis, we have two entities, CHIP and CCUS. So what is CHIP? CHIP is nothing but clonal hematopoiesis with a gene mutation having a variant allelic frequency of more than 2%. And for X-linked gene mutations, it should be more than 4%. Then we call it as CHIP. And for CCUS, which is clonal cytopenia of undetermined significance, it is a type of CHIP. That is, it should have clonal hematopoiesis and more than 2% VAF. Along with that, a component of cytopenia should be present. Coming to cytopenias, which are been harmonized across disease entities, whether it is CCUS, MDS, or MDS-MPN. Cytopenia is only called when hemoglobin percentage of less than 13 is seen in case of males and less than 12 grams per deciliter in females. Then we call it as anemia. For leukopenia, the definition is absolute neutrophil count of less than 1,800 per liter. And for thrombocytopenia, it is less than 1.5 lakhs. Coming to the classification proper, the main group being myeloproliferative neoplasms. This was the 2016 classification, and this is the present 2022 classification, where you can see CML, BCR-ABL positive has been removed and it is only CML now. Because to give a diagnosis of CML, now BCR-ABL is a must. You cannot have BCR-ABL negative CML from now on. And another change being chronic eosinophilic leukemia, NOS has been removed, and because a clonal component is a must now to diagnose CL. And also there is a shifting of JMML, which was prior, in the prior classification, it was in MDS MPN. Now it is shifted to MPN category. Why? Because it shows features of more like MPN rather than with
dysplastic features. And MPN unclassifiable is now termed as MPN not otherwise specified. Now coming to each of the MPN entities, firstly chronic myeloid leukemia. For its diagnosis, BCR-ABL fusion is a must.
Now we have only two phases, chronic phase and the blast phase. So why accelerated phase has been omitted is because with newer tyrosine kinase inhibitors coming in, we hardly get any patients with accelerated phase. It's become a rarity. This is one of the interesting cases which was reported at HCG Ranchi by Dr. Prerna, wherein a 46-year-old male with complaints of fever and leukocytosis smear was done and scanned under AI100. As you can see, neutrophils are accounting to 78% with beautiful morphology. And this is the basophils which have been captured by AI100 amounting to 3.18%. And few IGs were also captured like myelocytes, promyelos, metamyelos. And there was thrombocytosis as well, where the platelet count was 42 for 10 high power fields. So that was about BCR-ABL positive CML, CMLs, and now coming to BCR-ABL negative MPNs. So there has not been much change with reference to PV, ET, or PMF, but there has been an emphasis on newer genetic abnormalities which have a poor prognosis if found with PMF. So these are EZH2, IDH1-2, SRSF2, U2AF1, and ASXL1 mutations. So this have to be probed into if you are diagnosing a case of PMF to see the prognosis. And chronic neutrophilic leukemia, the diagnostic criteria remains the same, but there is more emphasis on getting a positive mutation of CSF3R, which is usually seen in about 60% cases of CNLs. And chronic eosinophilic leukemia has undergone a major diagnostic criteria change, wherein the hypereosinophilic status, which is more than 1,500 eosinophils per liter, per sustained hypereosinophilia, is reduced to 4 weeks from 6 months in the prior classification. And there is a requirement for both clonal and abnormal bone marrow morphology, and there is elimination of increased blasts. So in the previous classification, even though the blasts were increased and the entity didn't have a clonal component, we could have diagnosed CEL, but now it's not the case. We need a clonal component also for CELs. So that's why NOS is removed, it's omitted, and there is a better distinction between the DDs like hypereosinophilic eosinophilia of unknown significance or idiopathic hypereosinophilia. And in JMML, there has been some changes. There is exclusion of KMT2 rearrangement and monosomy 7, and there is more emphasis on detecting RAS pathway activation, which is commonly seen in JMML, and it is moved into MPN category now. So the next group of myeloid neoplasms are mastocytosis. Mastocytosis is a group of myeloid neoplasms where we see abnormal mast cells, whether in the cutaneous origin or of systemic, seen in multiple organ systems. So the broad category is kept as the same: cutaneous, systemic, and myeloid sarcoma. Only changes, there is an addition of bone marrow mastocytosis under systemic mastocytosis category. So So the bone marrow mastocytosis is a disease where the abnormal mast cells are located only to the bone marrow, and it should not have any cutaneous component or a B finding. And the serum tryptase level should be below 120 nanogram per ml. And other diagnostic criteria which have been changed under this are now they've incorporated CD30 and KIT mutation as well under minor diagnostic criteria. And KIT D816V mutation should have a VAF of more than 10% to qualify for a B finding. Coming to myelodysplastic neoplasms. So now MDS, myelodysplastic syndrome, is called myelodysplastic neoplasm, but the abbreviation is kept as MDS itself. This is to just harmonize MDS with MPNs. And a dysplasia is set at 10% for any lineage. And it is broadly categorized into with MDS with defining genetic abnormality and MDS morphologically defined. And unclassifiable component is removed now. So this is the 2016 classification, which we all are aware of, which has single lineage dysplasia, ring sideroblast, multi-lineage dysplasia, excess blast, and isolated deletion 5q along with childhood MDS. But in the present classification, we just have two broad categories with defining genetic abnormalities. Three genetic abnormalities are considered under this. One is MDS 5q deletion, MDS SF3B mutation, and MDS with biallelic P53 inactivation. This is a new inclusion. And also MDS morphologically defined is now categorized into with low blast, where the blast percentage is below 5%, with increased blast, where the blast percentage is between 5 to 19, IB1 and IB2 being blast count of 10 to 19% in the bone marrow. And hypoplastic MDS is also gained entry into this category, where the bone marrow should have a hypocellularity that is less than 25% for that age. And if MDS is associated with fibrosis, it comes into the IB2 category. And previously, what we used to call refractory cytopenia of childhood is now termed as childhood MDS with low blasts. And if it has a hypocellular component, it is hypocellular or otherwise not otherwise specified. And MDS with increased blasts, where childhood MDS with increased blasts should have a blast count between 5 to 19. So the next group of neoplasms are MDS MPNs. So in 2016, we had this 5 neoplasms, and in 2022, CMML is the same, and atypical CML, BCR-ABL negative, is now called MDS MPN with neutrophilia, and JMML is moved out of this group, and wherever there is ring sideroblast, it is replaced with SF3B mutation, and unclassifiable is now NOS. So there have been some diagnostic criteria changes in CMML. The most important one being absolute monocytosis, which is required to call it CMML, is now brought down to 500. Previously, it used to be 1000. And then the blast count is as usual less than 20%, and it should not qualify for other MPNs, MDS MPNs or CMLs. And the supporting criteria being there should be dysplasia in more than one myeloid lineage, and there should be an acquired clonal cytogenetic or a molecular abnormality. And abnormal partitioning of peripheral blood subsets is also recognized as a supporting criteria. So the requirements for CMML diagnosis is the prerequisites criteria are a must. Along with that, if the count is more than 1000, then one or more supporting criteria has to be met. And if it is between 500 to 1000, then 1 and 2, both criteria are necessary. So this is what I was talking about, abnormal partitioning of peripheral blood monocytes. These are classical monocytes, which are CD14 positive and 16 negative. If they comprise more than 94%, then it is a supporting criteria. And coming to the subtyping of CMMLs. There are two subtypes. One is myelodysplastic, where the WBC count is less than 13,000. And the other one being MP type, which is myeloproliferative CMML, more than 13,000 WBC count. And CMML is subgrouped into 1 and 2, and CMML 0 is eliminated from the present classification. So CMML 1 is less than 5% blast, and 2 is 5 to 19% blast in the peripheral blood. So this was an interesting case of CMML, which was diagnosed by one of our client partners, which was a CMML case. This was a 65-year-old male who presented with mild hepatosplenomegaly and fatigue, and his sample was analyzed under AI100, where our device has picked up a monocyte differential of 13%, and you can see a beautiful morphology of monocytes and some atypical ones as well. And also in this case, an atypical blast differential was 17%. It had flagged off 17% blast, where you can see very well discernible promonocytes as well as few monoblasts. So it comes handy in such cases as well, where it picks up the blast and shows it to you with visual evidence. So next category is secondary myeloid neoplasm. So this is a category which comprises of two entities. One is the neoplasms which arise post cytotoxic therapy, and one which is associated with germline predisposition. So there have been introduction of newer cytotoxic drugs into this. That is, PARP1 inhibitor is also gained entry as a cytotoxic drug, which can cause myeloid neoplasms. And also methotrexate has been eliminated from this. So this is the comparison between the previous and present classification, where myeloid neoplasms with germline predisposition. So the new entry is germline T53 LP variant, which is a new addition. So the broad category being with germline predisposition and existing platelet disorder or organ dysfunction, without platelet disorder or organ dysfunction, with platelet disorder or organ dysfunction, and with organ dysfunctions only. And the newer other new additions are the rasopathies and other syndromes, along with Downs and SAMD9 mutations. So these are all the new entities under the present classification. So the next category of myeloid neoplasms are myeloid/lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. This terminology has replaced the previous entity, that MLNs with eosinophilia and gene rearrangement. So some novel types have been introduced in this, like JAK2 and FLT3, ETV6, and this has to be MLN with tyrosine kinase fusions have to be eliminated or ruled out before calling it chronic eosinophilic leukemia in suspected cases. So this is the difference between the previous classification and the present. So these are the new additions: JAK2, FLT3, and ETV-ABL1 fusions, along with the previous PDGFRA, RB, and FGFR1 rearrangements. So the other confusing category is acute leukemia of mixed lineage or ambiguous lineage. So what are the changes in this? It's broadly classified into two entities. That is acute leukemia of ambiguous lineage with defining genetic abnormality, and the other being immunophenotypically defined. In this, there has been entry of these two mutations, that is MPAL with ZNF384 rearrangement, and acute leukemia of ambiguous lineage with BCL11B rearrangement. These are the new entries, and immunophenotypically defined is almost the same, but there is more emphasis on lineage specification. So to call it MPAL with a positive B lineage, it should show strong CD19 positivity. That is, the intensity on flow cytometry should be more than 50% of the B cell progenitors. And if it's CD99 strong, then only one or more of these B cell markers can be positive. But if CD19 is negative, then 2 or more of these B cell markers have to be positive to call it B lineage. And for T lineage is CD3, whose intensity should be more than 50% of mature T cells on flow. Or on IHC, it should be positive for non-zeta chain reagent. To call it myeloid lineage, MPO should be present with an intensity of more than 50% of mature neutrophil level. And to call it monocytic differentiation, 2 or more of this monocytic markers, that is NSE, CD11C, 14, 64, or lysozyme should be present. So this criteria has been laid down by the present WHO classification. And coming to the last entity, this is histiocytic or dendritic cell neoplasms. What are the key changes? There is inclusion of clonal plasmacytoid dendritic cell diseases in this category, and there is removal of follicular dendritic cell sarcoma and fibroblastic reticular tumor to a separate category. And RDD, that is Rosai-Dorfman disease, and ALK-positive histiocytosis have also gained entry into the present classification. So BPDCNs are also under dendritic and histiocytic neoplasms from now on. And to call it BPDCN, what is the immunophenotypic diagnostic criteria they have laid out in the present classification? So expected positive expression of CD123, TCF4, TCL1, CD303, 304, CD4, 56, and these markers should be negative: CD3, 14, 19, 34, lysozyme, and MPO. And immunophenotypically defined criteria is there should be expression of CD123 and one more PDC marker other than CD4 and CD56. And also all the other negative markers should be actually negative. All the negative markers should be negative. Only then you can make a diagnosis of PDCN, BPDCN. So that brings us to the end of the session. I hope you people are not clearly confused as in this animated video, in the slide. So I would like to end my talk by thanking my medical team, which comprises of Dr. Renu, Dr. Sharita, Dr. Richa, Dr. Chaitra, and myself. And thank you all. I would like to thank all the participants for the patient hearing, and Dr. Prerna, who is our guest speaker and who graciously agreed to come and talk over this webinar, and Dr. Renu ma'am for her guidance and support as always, and all my fellow pathologists, and our team member, Mr. Manohar Daka, who is always behind the scene, but is very instrumental in all these webinars, starting from making the flyers to arranging all the Zoom meets. Thank you so much. Thank you, Daka, and thank you all.
Thank you, Dr. Pavitra. That was a very informative talk on myeloid neoplasms. And now the forum is open for the questions. Any questions from the audience? Okay, if there are no questions further, so can we close the session, ma'am?
Yeah, so this is Dr. Renu here. So thank you all for taking time out on a Friday evening to attend this presentation, especially listening to this young pathology crowd who conducted this whole thing today. Thank you, Dr. Prerna, so much for gracing this occasion. Highly, grateful to you for taking your time out, and also for all the participants for their patient hearing. And I hope this was knowledgeable and interesting. And the take-home message, as usual, is about digital pathology solutions, which is very much the future, and so much in our practice in today. It's already there today, which everybody is using. And we hope to take this forward on a regular basis. And we hope that we get a lot of suggestions and comments from all of you. And we hope to look forward to you in the next coming sessions as well. I think one of the far more advantages are there that it obviates the need of the physical availability of the microscope, which we all use during reporting. And today the pathologist doesn't really have to sit in the office 24/7. That's not possible, and it was never possible. But today with tools like this, it is very easy to reach out, to look at the reports with visual evidence and give a diagnosis from literally anywhere in the world. Even if you're traveling, you just connect to a hotspot. You can see it for an emergency. You can even see it on your phone today. That is any internet-enabled device. And I think that's the far more, the convenience of remote access is, I think, one of the major advantages that digital pathology solutions provide for us today. It enables telepathology, creates a vista of opportunities for education and research activities. And I hope our way of teaching pathology changes in the future, where we adopt such techniques to, teach pathology to a larger platform out over there. It obviously removes the manual error and the ambiguity which is there with the human mind. We all have this, traditional saying when I was practicing in the lab, that after 6 o'clock, my mind is not functioning, the slides are not talking to me. And I was come back the next morning with a fresh mind, and more or less, it would be easier for me to crack a case. So that's how the human mind is. It undergoes fatigue. It has this ambiguity, biasness, and all of that. So somewhere I think these would aid us and would prove to be help us to be productive in our day-to-day reporting. And it's more collaborative, where you can take second opinions, at any given time in real time, without actually having the logistic challenges of actually transporting the slide or the specimen to other places. So I think in a nutshell, I think I would have just enumerated all the possible advantages that we could have. I encourage everybody to move on to a digital way of reporting in your day-to-day life, and to encourage the use of such devices in future. So I think we can sign off if there are no more questions from the audience. Thank you for all the encouraging comments on the chat box as well. We definitely look forward to connecting very soon again.